It seems to me that the malignant ependymomas are more likely to be invasive into the floor of the fourth ventricle and therefore more difficult to remove. And on the basis of that, the outcome seems poor. Secondly, the very benign ependymomas that aren't invading brain, that are free within the fourth ventricle aside from some attachment to the roof, are easy to totally remove. In that sort of situation, if I totally remove a benign ependymoma, I don't use any adjuvant therapy. Thirdly, I've seen aggressive ependymomas, mitotic figures, and pleomorphism, and necrosis, treated with chemotherapy. And when the tumor recurs, it has a much more benign appearance. So at initial surgery, it may be an invasive tumor, and at secondary surgery, it may be free and more easily removed.
I totally agree with your two first comments, except that ependymoma developed on the roof of the fourth ventricles are quite rare. But for the third comment, I can say exactly the opposite. I saw ependymoma receiving chemotherapy after surgery and recurring much more malignant than it was before. And it is the case of the young guy, because the recurrence occur under heavy chemotherapy with bone marrow transplant.
In the spinal cord, where I've had a lot of experience, I think I have operated on perhaps 75 intramedullary ependymomas in the last in the MRI era. In not one case in which the tumor was clear on the post-op MRI scan has been a recurrence. No radiation therapy, and no patient recurs. The same tumor in the posterior fossa seems to be very different. I think clearly what you're saying is correct. It's a surgical disease. And you just wonder, particularly with the tumors that you're showing, not the ependymoblastomas, if there was any way to remove it more completely surgically. I mean, could we have a chance of curing more? I think what limits us very often is the floor of the fourth ventricle. Well, I'm beginning to wonder if we do an operation and then on the post-op scan we clearly see that there's a fragment of tumor remaining on the floor of the fourth ventricle. Maybe we should go back and remove it. The biggest hazard is a 6th and 7th nerve palsy, maybe an internuclear thromboplasia. But I'm beginning to wonder, based on the spinal cord experience, which is a similar one under the microscope, if it wouldn't be possible to do more aggressive second look surgery in an effort to cure some of these ependymomas surgically. What do you think?
Spinal cord ependymoma is exactly that what I was saying about the ependymomas developed on the roof of the fourth ventricle. You can remove it totally and do no adjuvant therapy. But as I showed you, the quality of the outcome of these patients is clearly related to the kind of postoperative course they get. And if you take the Alexander case, I can swear you that 3 times I have the personal feeling that this tumor was removed totally. What I can say.
That's very much enjoyed your presentation, very much. The message I get from your presentation, if I fit that into the life I live at the moment, is that there is a distinct difference in the behavior of the ependymoma in different compartments of the central nervous system, supratentorial, posterior fossa, spinal cord. But above all, there is, it used to be, an incomprehensible set of data which are going to draw a conclusion, so that the only conclusion I can draw is that it is the relationship between the tumor and the patient which we still do not understand.
facts which can allow us to demonstrate that. But something confused me. In this case I present to you, the reference was local 3 times, as it is usually the case in eponymous. So that means I left behind some tunes. And the tune left in place regrowth, and that's all. About the different compartment and the different behavior of this tune, I don't think there is any difference between spinal, posterior fossa, or supratentorial eponymous. I think the difference is the quality and the ability for the surgeon to